This is a very, very simple, straightforward retrograde until we encountered an entrap and lost device. There we go. So it's an RCA CTO with very straightforward open patent vein graft, but to a very diseased PDA. The ischemia is in the PLV. So we use this relatively easy vein graft to the distal right, backwards, reverse cart very easily, then externalize to R350. The problem is I only post-dilated the subintimal space with a 2.5. I never realized we really had to deal with calcium in subintimal space. I've never had this problem before. So then we had stent regret after 3.0 by 32 drug stent, 3.5 non-compliant, unsuccessful in fully dilating it, 3.5 unable to deliver. Then 4.0 ruptured. When it ruptured, it obviously got entrapped at the site of underexpansion. You could see me pulling the balloon. Now it's yanking the entire vessel towards the guide. So at these, for these kind of complications, you need some sort of algorithm, some sort of solutions. You can't randomly do things. So the first thing is a wire technique. So the first thing to do is advance a wire next to the entrapped device in order to deliver a balloon and free it. So we attempted with the Field XT, unsuccessful here. You can see on the left-hand side. The Pilot 200 Pro 12 was all unsuccessful. So a couple phone calls to the community members. The next thing you could do with the wires, use a very stiff wire, Pro 12 Hornet 14 Astato, to jab at the device, disintegrate the balloon, break up into little pieces. That may help. So we attempted that. That was unsuccessful. So that's the wire technique. The next thing to do is to retrieve this. There are multiple retrieving techniques. One is to snare. The problem with snaring here is because I'm externalized. I didn't want to snare the retrograde wire as well and choke the heart. So I cut the top of the balloon, advanced the guide liner as close as possible to the site of entrapment. You can see it's actually at the site of entrapment. I pull as hard as I could. The problem now is I separate the push segment to flex segment. So remember that. So that was the one thing I didn't realize. I kept pulling and then it separated. So now I have an entrapped device and then a lost device. So I don't have access to this balloon except that it's on the externalized wire and it is within the guide liner. So this is what you have right now in this situation. So the next thing we tried was we said, might as well try a snare. The snare here would not go past the axillary artery because of the proximal part of the guide liner, as well as parts of the balloon is hanging there somewhere. You don't know where it is. You can't really ride it over the snare. So a couple more phone calls to some retrograde operators. So they said that what you could do now, because you have a retrograde option, is to deliver your gear retrogradely and push free the antegrade entrap device. So you could advance your microcatheter or balloon. So we attempted that, but those devices would not go to site of entrapment. But that's an option that for you to think about. We attempted to advance a guide liner in a retrograde fashion in order to provide more support for retrograde gears to push free. We were unable to. So that's the other option. Then we attempted with a knuckle. This is a Pro 12 knuckle, which is knuckle to modify the plaque. Now in this situation, I didn't really want a balloon because we have a stent that's underexpanded. You may collapse the stent further on your balloon, so I didn't want to deliver the balloon. So now we're out of options. So what I had to do was do a last-ditch effort, remove the externalized wire, and advance the balloon in the guide liner. So this is now the situation you have no wire on your lost device and your entrapped device, but it is in the guide liner, and that's a retrieval device that you could use. You advance a balloon, inflate the balloon to trap the entrapped balloon. Once you have this, my hope is that I will pull the whole thing free, but if I don't, then I would just have an entrapped balloon hanging outside the aorta. Now, what's the worst outcome? So we call a surgeon and say, what's the worst thing? They said they're not going to come in just to snip at the ostium of the RCA. You're just going to anticoagulate or antiplatelet, so might as well do this finer maneuver. So I said, okay, well, I have nothing to lose. What can you do? So you can see here, we're pulling as hard as we could, and the whole thing came free. On the right-hand side of the picture, you can see the inflated balloon trapping the entrapped balloon that is torn off on the left side of the picture. So this is what the image looks like, and there are multiple things you could do. You could give up, or you could do rota stent, and that's another topic on its own. There's aortic dissection. This patient actually did well and was home in a couple days without any problems. Came back, but there's no distal vasculature, so we didn't see any long-term outcome. We didn't proceed on with this procedure. So the main thing I learned here is that even in the subintimal space, you can have stent regret. So now I'm learning to be more patient and prep my subintimal space better after the reverse cart. Entrap device can happen. I know a lot of you guys may know the antegrade option. Think about retrograde option as well to push it free. And it's very important to have community support like these guys, expert operators, because collectively, you don't see this often, but collectively, we have collective experience, and next time we see this, we could solve it more efficiently and safely for the patient. Thank you.
Great save. I just have one question. Yeah. Could you have pulled the retrograde, like you pull from the SVG side? Because what happened in this, the balloon's supposed to rupture this way, right? In this situation, I think what happened is actually parachuted. The balloon ruptured transverse. So you have that distal end of the balloon basically became a parachute, and the more it's kind of stuck in a stent. This is what I think. And could you have pulled everything the other way?
But it was an anterograde balloon. So we deliver anterograde balloon. The only access to retrograde was the externalized wire, the R350.
Exactly.
Once you pull that, then you got nothing else. Then it's not riding on a wire, so you can't. You have to push it free from the retrograde end.
But like if you pulled it the other way, you might have been able just to release it. Like it might have come so easy.
Pull the R350?
Through the graft.
Like, for the R350.
You have to have something on the end of the balloon, the wire, that actually it's going to grab the balloon with it.
Oh, but there's nothing because it's R350.
Yeah.
It just slide off.
Yes, exactly.
Really great case, man. And we had a recent ruptured balloon as we were trying to anchor a guide liner all the way down. It was actually a trap liner, which turned out to be very fortuitous. Two things. The balloon is rupturing at that monorail transition. So you can't tell initially on fluoroscopy, you only see the two dots of the balloon, but you actually don't realize it's actually 30 centimeters back. And so if you have a balloon pin strategy or a trap liner, then you can actually take advantage of that and just empirically pin, and you just pull the whole guide out as one piece. But recognizing that, you actually really, you have the second, you'd actually examine the part that came out. Mm-hmm. That's one thing that's really important, is to not assume that it snapped at the balloon tip.
Exactly.
Yeah, absolutely.